I decided to break it down into three things. We'll give a brief overview because we, of course, have a great panel who's here mostly what you want to hear about. And, of course, we have a lot of fellows and everything, so a little warm-up. One recommendation that I like that's outside of the guidelines, and then two small data dives on the medical therapy guidelines that I found interesting, kind of going through it a little bit more on the up-to-date ones. The first part, so two parts. The first one, office evaluation. At least from the AUA guidelines, the initial one is history and physical, then you do your questionnaire, and then your analysis. And then with follow-up, they recommend you can either, or not recommend, but it's an option to do a uroflow and a PVR. The funny thing is, if you actually look at all of these, the positive predictive value, the negative predictive value is shockingly low. I mean, we know you can't diagnose it with any of it, but why are we doing this? You know, it's kind of interesting. It's weird to get to a disease and treat it without any test that actually diagnose it. And so, of course, people have like, well, why don't we just do urodynamics on everybody? Whether you look at the upstream trial or anything, all the head-to-heads don't seem to show improved outcomes with surgery or rates of surgery, even if you actually technically diagnose bladder outlet obstruction or a failure of the outlet. So that doesn't even work. So we're dealing with a disease that, you know, what's our diagnosis? What are we dealing with? Now, there's been some hybrid approaches. We have the Eurocuff. We have measuring the wall thickening of the bladder. Maybe that could show whether or not they would have good outcomes with surgery. Or even some people have suggested an intraprostatic size to also predict outcomes of surgery. Those are still ongoing. Nothing's really definitive in the data that say this is the thing to do. And so why is this? Why don't we have tests? And even if we do have the test, it doesn't get us to where we need to be saying, hey, if you have this surgery, you're going to do well. Well, probably because we're not really treating BPH. We're really treating LUTS. And I stole this graph from the EAU management of the male lower urinary tract symptoms. And I think that's the problem. Is it's never one thing. It's a lot of things. The darker blue is what's more common. The lighter blue is less common. Now, the nice thing is, you know, we do a lot of things to try to, you know, pare down what we're actually treating. How many people here do cystoscopy? I'm not going to say for every BPH, but for the majority of their BPH patients going to surgery. I think most people, and I think that's definitely a switch since I've come out of residency. I mean, that rules out a lot of things. Of course, the reason it's on the guidelines now is more of the size and shape of the prostate, but it does rule out a lot of things here on the right side. Of course, the urinalysis, checking for an infection, everything like that. So really what we're left with, other than actual BPH that we're looking for, is these four things. You know, if you look at chronic pain, pelvic pain syndrome, we just talked about that. I think that's a big deal. I think that needs to be more incorporated into finding out beforehand. Of course, the neurogenic bladder dysfunction is a whole nother black box. But also the main focus, what we're really looking at other than BPH is, you know, that nocturnal polyuria, that overactive bladder, due to overactivity that is difficult to kind of treat, you know, or figure out beforehand. Is it a result of the prostate? Is it not? So some people have tried to do this, at least add a few more questions. The Lower Urinary Tract Research Network has come out with their own AUA score. I don't think it's ever caught much traction. Does anybody use anything besides the AUA symptom score? Any other questionnaires? No. So, you know, people have tried to catch these things, and it just hasn't caught on. However, what I recommend, at least what I do from my practice, and I think it's a big deal, we do it all in our sacral neuromodulation patients. It's kind of required, but the bladder diary makes a big deal for especially those not straightforward patients. Because while we have the AUA symptom score, this is clearly what the patient thinks is wrong with them. They're answering questions like, hey, what do you think is wrong? The bladder diary is actually what is happening. Now, of course, I don't think one is better than the other, because whether the patient thinks they're happy or not is kind of the most important thing. But it's shocking when I do both of them how different they can be. What patient actually circles how many times they get up at night, how many times they have urgency, and then when they actually do the bladder diary, they're not usually the same thing, and it really sets expectations for surgery. And then the reason the one I have over here, which is from the ICIQ thing, is this the only validated bladder diary? Does a validated bladder diary matter? No, but what I really like is it has instructions on it with an example. So when you hand it to a patient, you don't have to sit there and explain it to them. You're like, the instructions are here, here's an example. So I do highly recommend using theirs. It is validated, so that's another feather in the cap, but also it already has the instructions all on there. So I think that really helps with the other two things other than BPH. And we can scope people, we can do uroflows, but if you have any questions of concomitant diseases, having that bladder diary, I think, really helps, sets expectations for what the surgery can or can't do. So moving on to the second half, non-op management. Here it is. This is the algorithm from the AUA guidelines of the medical therapy thing. What I found interesting, what's of course changed in my time, is daily tadalafil, can't say the trade name, I guess, is the exact same efficacy as tamsulosin. It's been proven time and time again, meta-analysis is everything. So, and if one doesn't work, the other one has some efficacy, and that can switch back and forth. So I have a question, who here does tadalafil as first-line therapy over tamsulosin?
I give both and offer the patient.
Offer the both?
We say the biggest side effect of Cialis is poverty, because you guys have different payment plans, but for us, like about $120 a month, or they get Flomax paid by the government. So. Okay.
Oh, wow. I mean, we can get it down to about $30 a month. Is anybody getting anything different for Cialis?
Oh, on GoodRx, you can get it for $7.83 yesterday.
Even better.
There you go. But okay. GoodRx is huge for that. But I also think that it matters, what the etiology of their issue is, right? Like you might take a patient with sleep apnea who might actually do better with tadalafil than tamsulosin. So I do think there are times when one works better than another that we still have to tease out.
Sure. And so as an overall, they work just as effective on, maybe not for the type of patient, but 70%, about 2/3 of men who come in with BPH symptoms will have ED. So consider it as a first line. The other thing that was interesting, of course, they keep harping on the finasteride. They say anything over a 30 cubic centimeter prostate, consider it. And that is also whether a PSA 1.5. And where's that data really come from? Really kind of three main studies. The PLES study, one of the most famous ones, that essentially any PSA less than 1.4 or a prostate size less than 41 really showed no improvement whether they had finasteride or placebo. As soon as they went above that, finasteride had efficacy. If you go to the Olmsted County in Minnesota, same thing. Need for treatment, actual intervention, surgery, increased only once their PSA went over 1.4 or their prostate size went over 30. And those numbers continue to be correlated. And then a Crippen study out of Norway showed a 78% positive predictive value of a prostate when it's over 30 cubic centimeters. The PSA is likely to be over 1.5. So those things usually go together. I mean, I think we've all seen the PSA of 1.2 and a 80-gram prostate. It does happen, but the reason those are separated is that size and that PSA for most men are correlated. So just keep that in the back of your mind when the PSA comes really low. I don't know, how many people ultrasound almost every BPH patient before surgery? Not as many, but we're getting there. So if you don't ultrasound everybody before surgery, watch out for that 1.5 PSA or less. So take-home points, that was a warm-up. Strongly consider the ICIQ bladder diary. It is validated, most importantly, has the instruction on there. And that tadalafil is really just as efficacious as tamsulosin, and most men with BPH have ED. And then correlate the 1.5 PSA with a 30-gram prostate. Not perfect, but at least keep that in the back of your mind. Thank you.